You're watching Daybreak. Thank you for staying with us. The hashtag on X is Citizen Daybreak. The SMS code is 22422 at Citizen TV Kenya and at Ayub Abdikadir. Dr. Brian Lishenga is the chairperson, the Rural Urban Private Hospitals Association of Kenya. Dr. Daniel Moai, President William Ruto's advisor on health financing. MP Seme constituency, Dr. James Nyikala, member of the Health Committee, and the chairperson of that committee, Dr. Robert Pukose, MP and the Best constituency. Yes, Dr. Lishenga.
Yeah, so with regard to readiness, level 2 and 3 facilities in this country are supposed to operate under the primary healthcare fund. As we know, first, number one, the allocation to primary healthcare is wanting, about 4.1 billion. We keep being told that it will improve over time. But I want you to note something, Ayub. Today is 1st of October. 1st of October means that we have started quarter 2 of the financial year. And this quarter 2 for us means that we should be receiving money as providers for outpatient capitation for the month of October, November, and December. That is supposed to happen by contract within the first month of every quarter. As we are talking today, we do not know who is capitated to which facility in Kenya. Even if you're talking about continuity of service, how am I offering outpatient services to people who are not capitated to me, and yet I have a contract that says that every Kenyan is supposed to belong to a primary care network. Now, I don't even know which primary care network I personally as a provider belong to, let alone the one which the patient who is seeking care from me belongs to. Number two, the allocation of money to that same primary care network is supposed to come from a global budget where they are saying each Kenyan is allocated 72 shillings per month. That global budget is insufficient for Kenyans. We have allocated 4.1 billion for a population of roughly 50 billion. We are supposed to have allocated 45 billion at the minimum. The money is not there to provide that primary care. But I want to pivot very quickly to, you gave Mheshimiwa a lot of time to talk about Piero and these HIE things.
A lot of time to explain as well.
To explain this. Can I say this from a provider perspective? What we are expected to do as providers is to connect our hospital management information systems, if you have them, to the HIE. Now, as at today, as we are talking, no single provider in Kenya, no matter how sophisticated your HIE is your HMS.
For simplicity, what is HIE?
Health Information Exchange. Okay, so it is supposed to be this big pool of data where all systems that all registries are connecting to, including my own hospital management information system where I keep your records. So that software I have on my computer in the hospital also supposed to connect there. Now, so you are assuming that I have a software. Some hospitals, actually, the census that was done last year found that only 30% of hospitals have that hospital management information system. 70% don't have. But now we are expecting everyone, including those 70% who don't have, to connect to that HIE. It's a very technical thing. As at today, regardless of which hospital you are, nobody has connected there. But even more interesting, the HIE itself has issues because, one, it is supposed to have data from the IPRS, the Registrar of Persons, which includes information like your ID number, etc. That data is still having issues, and when it fetches, it produces errors. It's supposed to connect to KMPDC data, which is supposed to give a record of the physical location of a health facility, the number of services that are available in that health facility. Does it have X-ray? Does it have ultrasound? Does it have lab? The doctors there, what are their registration numbers? The nurses, what are their registration numbers? It is supposed to connect to Nursing Council, supposed to connect to Kenya Medical Laboratory Board, Pharmacy and Poisons Board, supposed to connect to all this. And that's why I agree with Dr. Bukose, it's a lot of connections. But KMPDC registry, as at today, also has issues. You cannot go into KMPDC registry and ascertain Dr. Lishenga is here, he works here, this is his registration. Those data points are not there. None of the resources that we are saying, 104 billion, if you look at that circular, has been earmarked to building the registries of KMPDC, to building the registries of the medical lab. So what are we really spending the money on? And finally, on that same point,
yes,
we have consistently said as providers that please do not introduce parties to SHA who have previously frustrated healthcare system in Kenya. One of these ones has been those who manage the teacher scheme. They have been doing bad things there, and the teacher scheme and police scheme have been having uproar throughout. Now, if you look, you will find that the same parties have now been introduced into managing the HIE and all these issues. This information is in the public domain. This is why we are facing a trust deficit in Kenya. And today there is no HIE, this morning. Haven't we just been told patients will be seen? How are they being seen? Today, this morning, there is no HIE. Haven't we been told pre-authorization for dialysis will happen? Why do we need the HIE? If all these things are possible to happen, even without that system, and we are telling Kenyans it will happen seamlessly and it will be better. Okay.
Yes, Dr. Nyikala, I'll come to you. And I'm sure you want to respond to what Dr. Pokose had said and also your response. But let's get this soundbite, if ready, from the health CS, Deborah Barasa, who spoke yesterday, and that is the first bite when this is in response to a question by the deputy chairperson, that is the vice chairperson of the committee, and Chukwuemeka Mangombe lawmaker Patrick Munene. This is what she said.
Please, CS, how are you going to deduct that money? You can explain to Kenyans so that they know how the money is going to be deducted. Through M-Pesa, through what? So the order, Chairman SHA, this is, the CS has not given you the permission to speak. It was the CS who we wanted to understand how is the money going to be deducted for somebody who is informal, and we want the banding. How are you going to do those bands? Yes. What, how have you categorized them? That this category will pay this much, this category will pay this much. We just want that flow.
Yes, for Ministry of Education, the challenge was the bands were larger, but for us, the bands are smaller. And that is why...
Which are, just explain what's that banding, what are the bands you have?
So we will give you the report for the bands, but what I can assure you is the accuracy is 95% with the low band, and we are able to...
Orders, yes.
Yes.
We want you to give us the bands. Yeah? We want you to give us, I'm giving you the opportunity, because Kenyans are listening. They want to see their cabinet secretary for health telling them that when you are in this, we are going to categorize you based on this means testing.
Dr. Nyikala, there was also the aspect she mentioned. We'll have that second bite about the Hustler Fund and how that's a possibility as a soft landing spot. But it appears even for the CS, it's hard to explain for her herself to even understand how that should be done.
She's new. Let me tell you. The basic issue we are discussing here is what we have taken out to people. That we have taken out to people. That we are prepared. I like what he's saying, that we are starting. If we say we are starting, then it gives us room to make all these changes that are necessary. But if we insist we are prepared, we are shifting over, that is where the problem is. So the CS actually didn't have information. I don't think there are even bans. So she went to the Ministry of Education where there were bans. And that's a bigger issue. We don't want to go there because we'll come to means testing, which will come here later, which again, I think we have to the problem in education. Now, look at the first video. What you are seeing there is lack of information. There are two people who are clearly not informed. The patient was not informed of what change is going to take place. The provider that called that person and said, if you come tomorrow, come with money, is not informed of what is going to happen. Because Mr. Moore here was saying information is going out telling providers that they cannot turn people away. That person did not have that information. So I repeat what I said. It is what you are telling people out there. And he was very right when he said, when you are rolling out, I don't want to say we are rolling out. Yeah. We are starting to make the change. And Kadir, you know, living for long is a very good thing, if your mind remains. You know, I can go way back. When we were discussing the act, we said transition. We gave this thing, the act made it look like we will move one day from SHA, from NHIF to SHA. Luckily, in the provision, there was retained that contracts will be go over. That is what is helping the whole situation. I can see that. And what I'm saying, living long is good. He's telling me the NIDA is opening accounts for level 2 and level 3. And the CS and the PS also told us that many counties have not opened accounts. Those accounts were there, they were closed when the devolution came. We opened them in 2005, again with the help of the NIDA. You know, so, but coming back to the information, we need that information. Just tell people, Mr. Mwai, you are advising the most important. Tell people clearly what you are going to do when you call this thing Rollout. Tell them we are starting and there will be a changeover. And say even people who have NHIF should not fear. They will get the services. The help desk will help them. Yeah. That alone will take a lot of it away from us. Okay. Because that's what we are doing. Now, when you now come to the system, the procurement system, again, information. We don't have all the information. And I'll say, what we have that our chair has told you is the procurement process as presented to us in the committee, which is the specially permitted procurement procedure, which then allows that they can go and now negotiate with one person. We still had a problem with that at the committee, and they'll tell you. Once that was, we asked the basic question, how did you pick who to send the call for proposal? Why did you just pick Safaricom? That question has not been answered, and my chair will tell you, we are still expecting some information from the ministry. Even how approval at cabinet level was done. But your chair has cleared it. Listen to what I'm saying. You called us here to get information here. The information you had yesterday. So even now, when we go to the people, when you talk about a payroll, we know if you started from that level, the Treasury and the Ministry have given us the letters that exchanged. So true, they were approved. So that process is right. But what is the information behind the process? Who is a payroll? We also raised that. And remember, my chair here will tell you, we actually we are still going to need more information. Who are the partners of a payroll? This consortium is a consortium of Safaricom, Apero, and Convergence. Apero itself is a consortium of sorts. It has also got people behind it. So now let me tell you, at this time in our
let me give you the details, because you don't want to mention it. So let me do it for you. Because this is from the Business Registration Center. Apero is owned 100% by SHA Africa Limited, directors, 2 Kenyans, 2 Indians. Beneath that, Convergence Network Solution Limited. Beneath that, Convergence Holding Company Limited, 90% owned. Pitfield Auto Limited, 5% owned by Dorothy Kiprono. Abdullah Abdishek, 5%. Isa Sheikh Mohammed Nil. This is the web of people you're dealing with.
Exactly. So we still even told the ministry, we are still going to look at who is a payroll, what is connected. That is where there were even things that say some people, like Mr. Ndi was mentioned, his wife, and then they're linking back to Ndi being the advisor of the president. So these are the conflict of interest people are seeing. The committee has not finished with that. What we said can go on. This initiation that they're starting to initiate the process, I don't think we want to stop that initiation of the process. I'm calling initiation of the process, not roll out. So initiation of the process can go on. But we are going to still look at what? Who is a payroll? Even if you look at what you are saying in the standard, Mr. Moy read and he read a bit of it, he left the other one out very cleverly. What does MPs say of Ndi farm? You hear, they bring in the Ndi farm here, even in the thing. So these are the things we are saying out. So we are still got questions to ask, particularly about the background of a payroll. And we told that to the ministry very clearly, that as you are rolling out, I'm calling as you are initiating the change, now we are going to look at all those we are going to look at the background. Now, if you
Dr. Just hold on. Let me get to Dr. Moy. I'll come and finish up with you on that.
There is even more. I even wanted you about the system itself.
Yes.
Again, information. Let me just say this.
Yes, please, briefly, yeah.
You know, this thing is big. And he is right. And he is right. And he is right. But as a country, we are not linking all the information together so that everybody is on the same phase. This thing, what it means, even his information will be plugged into it, HIE that is calling it. I asked one question. Is it going to be compulsory or will seek the concurrence and of the private hospitals? Even that we have not got clear. Because if you are going to have people to put the information in yours, that is, it will also involve even KEMSA and drug supply. It will involve the regulatory authorities will also link in. It is a true superhighway. But you know, in superhighway, there are very many cars.
Okay.
And if the lanes are not kept clearly. So, but let me tell you.
Please, Dr.
The question, we also asked the question of 104 billion.
Yeah.
And we said, if you talked only to Safaricom and this team, couldn't there have been other people who could have got it cheaper? This procurement process does not stop you from getting other consortia that can give it to you cheaper. So your concern is still right. Now you even said payment. I want to take everything you said. We also asked, who is going to pay? And the answer the PS, not the CS, gave, is that the users will actually, they'll be returned from the users, they'll pay. That is what Dr. here said. They'll pass that on to Kenyans.
Yes.
And Mr. Moy said, that's okay. But let me tell you about that one. As of now, we asked, if the users are going to pay, surely by the time you are committing us at this level, you must have done some workout, cash flows, how much will it be, make some simulations, and you tell us this is how it is going to be paid. What was the answer? He'll tell you, we are going to get that.
He'll tell us more. Okay. Yes, Dr. Moy. Yes.
He'll tell you, that's what it is. That's what the CS said. We are taking for information.
Thank you.
We have not given anybody a clean bill of health. We are just saying, you start the initiation by a lot of things we are going to look at.
Thank you. Yes, Dr. Moy, I come to you on this. Let's focus on now the primary healthcare fund, which by requirement was or requires 50 billion Kenya shillings. The allocation done in the signed appropriations bill is 4 billion Kenya shillings. The social health insurance fund, the target is to raise 148 billion annually. This is via members. The emergency chronic and critical illness fund requires 75 billion, but allocated only 2 billion Kenya shillings. So this is a total of 6.1 billion out of the total required of 273 minus 148, which is via members. So in as much as you have talked about today's relevance in this entire scheme, how do you address, being the president's advisor on health matters in terms of its financing, how do you address this deficit footing that we are starting on?
Thank you very much. I will not begin from deficit. I'll begin from why that fund is there. One of the key problems that we see in this country is that people bypass small facilities to go to big facilities. And this is driven by the fact that in the past, largely, more so if, for public facilities, NHIF actually, if you look at its payments, were largely on higher level facilities. So people would surpass a facility that is closer to them, level 2 or 3, this is dispensary or health center, to go far to seek care for services they would have gotten closer home, because the incentive is to push people to go far. So the thing that is there is that one of the key things that have been highlighted in the panel of expert report that was written in 2019 is the fact that we should be able to purchase services from lower level facilities also to actually not make the healthcare system very expensive by pushing people to levels they need not go to seek care in. So that's where the issue is at. Now, to do that, you need two things. Either you can just push money into hospitals and assume that that money will provide outputs. Or you can say, let me purchase a service that is provided within a public, private, or a faith-based entity. Because so that you give the patient power to go where services are available, to begin with. If it is the Shenga's facilities of services, they should be able to go there. and not say you must go to a public facility if the services is not there. That incentivizes not only the private facilities, but more so the public facilities to actually provide the service, because you receive payment for a service. Now that will force the facilities to actually hire the right human resources. For instance, if you are being paid only when you provide a service, and that service is supposed to be provided by a clinician, then you must hire the clinician for you to access the money, even if you don't like hiring. As you have seen, there is quite a problem with human resource deployment for human resource. Then the facility will be forced, not because of loving these people, but because you need them to provide a service for you to be paid. So it's an incentive that goes to that level to enable the county government facilities, for instance, to actually hire.
So how do you gap in? How do you fill in this gap? Because if primary healthcare fund, as you have said, is being bypassed by many of those who require medical attention, but is now starting on a footing of less than 46 billion, where will this money come from?
So the reality of the matter is that government allocates resources, and the chair of our committee is here. And you need not get all the money in the single allocation, because the supplementaries comes over time to actually commit resources as they come. And we cannot assume this country is a third world nation. We must be in the reality that we are balancing the resources we have to make sure that the government continue moving. Now, in this, then, we say that the expectation is allocation of resources as we move. But the committee, through the parliament, has also given us resources to begin for the next 3 months or so. Our expectation is that we'll probably get to a range of around 35 billion by the time the year ends. Because
that is also next year in June?
Yes. So it is conditional on enrollment and registration by Kenyans. Because for you to access primary healthcare facilities, you only need to register. You're not paying, but you need to register. Now, that is trying to solve another problem that Lishenga tactfully has not mentioned, that they have for a long time struggled to have facilities. People choose facilities. So you tell somebody, choose a facility that you will go, but you don't know where the disease will find you. So if you had a ability to choose where you will get sick, then you get sick to where the facilities you chose. Now, when you just do what is called selection registration, you choose where you live, right? And those majority become your primary level facilities. That is tier one. The first thing is that you indicate where you live. The system has mapped facilities by where they live. Now, this was published almost 3 weeks ago or so. Many facilities have come back and said, I cannot see my name, I'm supposed to be here. We have been adding. Earlier, he should tell you the struggle they had for you to be included in NHIF as a facility to provide. But now we are just saying, you have been empaneled by the board, because let's allow other government institutions to do their work. Okay. The board has said, you are ready. Then you should actually be brought in and given a chance to provide service as per your regulator.
Yeah. So the funding about primary healthcare tick. Let's come to this most critical one. Emergency, chronic and critical illnesses fund requires 75 billion, allocated only 2 billion. Where will 73 billion come from?
Thank you very much for that. That's a good question. The chronic illness are covered in 2 ways. Number one is that it is through the correction that are coming from the Social Health Authority.
That's SHIF.
Yes. When you go there, you will find the dialysis, other renal, whatever, they are included there, and they have benefits. Those benefits have not even been exhausted so far, because we are rolling out. Now, you would say that it is, you cannot assume it has actually been exhausted before you even start, to begin with all fairness. So what we need is to monitor the SHIF corrections. We are also monitoring the SHIF for chronic illness payment, because the higher fund is only taking care of offshoots of the SHIF. That means you have gone above and above, because we say 5% of the population globally incur catastrophic spending because of health spending, 5%. Therefore, the 95, if they come together in a solidarity principle, then they can shield the 5 from becoming poor. Now, I want to tell you this. The emergency component is where the biggest gap is as of now. However, the Parliament allocated us 2 billion. That money is almost enough, so to speak, to take care of emergency evacuation and 24-hour stabilization, as per the package that has been listed. And he'll tell you his hospitals are having big problems because every time an emergency patient comes, they are forced by law to actually address, treat that person. But they're also Kenyans. Sometimes, you are torn between your private capital and being a Kenyan. Because now they are good Kenyans. Yeah. They have been giving services. But a lot of hospitals have bad debts because of taking somebody who was in emergency status and they had nowhere to claim. But the bad ones, not the ones Lishenga is leading, probably some are there. The bad hospitals have actually been saying, I don't have a bed. Yeah. Therefore, a patient go around with an ambulance until they die in the ambulance. So the money to take care of the emergency, which you need not pay, you only need to find yourself in an emergency status, right? Then that money has already been provided by the committee. So which is the 2 billion allocated? Yes.
What if it's exhausted? Because you talked about then the fallback plan is the collections and the social health authority, isn't it?
No. So emergency.
In the event this is exhausted.
No. So we have looked at, you see, data is very important. Yeah. We did not just wake up and say these things can be done this way. There have been almost a year plus of people who are expert in analyzing actually your premiums, looking at consumption need, looking at disease and how they are in country. We estimate that the total need for that fund is in the range of between 2 billion and 2.8 billion. 2.8 billion. So we have a 2.8 billion that is not already covered. We are monitoring, of course, because again, let's also look at, you cannot allocate all these monies at first. You are rolling out. You need to monitor the utilization, and you change as you go. I want to just give you one example. Yes. When this good man here, I've been with him for a long time in this struggle for financing. And they wrote a perfect bill in 2003 called Giru Bill. The facts have not changed. The same way for you to diagnose something, you use the same methodology. Even for healthcare financing, there are basic principles that must be followed. They wrote them 2003. It was the DMS.
2003, 2005, yes.
And that period of time, if we rolled out that what we are trying to roll out now, we'll not be where we are.
Okay. Hold it there. Let me get this sound, Dr. Pukosa, and I'll respond to this.
I'll give him a little of why we didn't roll it out.
I'll give you the time. Yeah. So let me hear from Dr. Pukosa. And with this sound right here, the second of the CS who yesterday appeared before his committee, he chaired, and this is what she said.
Because the Chief Justice, we are rolling out tomorrow, we have been told by the DCC, people should say *147#. Then there was somebody advocated from the ground and he said, can you explain to these women the 2.75% of the earning and the annual payment? So I want the answer I should have given, and CS don't tell us you'll give us, because everything is contract you'll give us. This one you'll give us. And you leave these people of the media thinking that they have things we discuss with the ministry behind locked doors.
So
if there is one of your officers, you can give opportunity to give. You know, Turanira, I have issues with, you are not advising the ministry. You don't work in the ministry. You are a presidential advisor. And you are the one who will take the information that this is what happened in this meeting. So you should not be the one coming to the defense of the ministry unless you work there.
Okay. The next one is now where that was after the question by you, Mr. Chair. And this was then the inability when she, number 3, that the team will be playing here, then we'll respond to that because we are moving next to now the deductions that will be made of the 2.75%. Okay, so once ready, we'll get that. And there was, Mr. Chairman, the fallback that she explained that the Hustler Fund is an option. We'll be getting to that soundbite. And your question was on then, how do you bring in those who are in the informal sector, those who are self-employed, because the unemployed is catered for, well, clear stated, and the deductions will be smooth. And it seems there's no sufficient explanation and the proper information flow of how, despite the relevance of today's Tuesday's relevance.
You know, Abdikadir, I was in the same position you are today when you're asking me. So I needed that information. And since Dr. Mwai is here, I think he's the right person to give response, because his colleague, Dr. Thuranira, wanted to respond. But we wanted to give the ministry an opportunity, because they are the implementers, to be able, they must be able to understand. But now it seems we need to, we can escalate it to Dr. Mwai here.
Yeah.
So that he gives a more satisfactory answer. Dr. Mwai, maybe.
It will link to why we didn't roll.
Yes.
Thank you.
I think they're just throwing.
So you're in the dark as well as many Kenyans are.
I'm not in the dark.
Yeah.
But you know, I'm the one who is asking questions.
Yeah.
I'm the oversight.
Yeah.
And I needed this information to go to the Kenyans so that they also understand how this, how we going to, when we say we are going to charge them, each person is going to pay for membership. That is, their contribution is going to be 300.
Yes.
How are we going to base it? Because this came up with the issue of the means testing. Yeah. So that how can, you know, this means testing thing is not very clear.
Yeah.
And despite the fact that the Director General, Dr. Moth, explained to us that they did sampling in 8 counties.
Yeah.
And their sample size was about 2,000, which we felt that is a very small sample size for us to make any conclusive for that data sampling. That's small. But you can find that the CS was, I think she's not well informed. And up to today, we've asked, we still expect them that they'll be able to give us a proper answer in terms of how are Kenyans going to be put in the various categories, so that you have the indigents, the poor Kenyans who cannot be able to pay. Then you have those who can be able to access other credit financing within the system. And then you have those ones who can be able to pay, and you have others who are working.
Yeah. And that is
so
well
for those who are working, they'll pay
2.75%
of their gross salary. I think that is very clear. But for these other ones in the informal sector, I think that is where the means testing comes in. But we need to understand, how does this means testing work?
Okay.
Maybe Abdikadir, let me just say something. Let me just say something. And Mwai knows this, Dr. Mwai knows this. I have written extensively on proxy means testing and why it was the wrong approach for us to determine what people will pay in the informal sector. Just for people to understand, what proxy means testing does is it uses a set of variables, things like your household characteristics, whether you have piped water in the house, for instance, whether your floor is tiled or mud, whether you own a tuk-tuk or you walk on foot. These kind of variables, the education level of your spouse and yourself, you know, this is the set of variables they use to determine how much you should pay as premiums. But the biggest issue with proxy means testing is that it is going to over-exclude people who are not poor. In other words, the intention of proxy means testing is to narrowly target the poor correctly so that you get only those who should benefit from government subsidy. In other words, you use it to get only those who should be classified as indigents. And you exclude others who now should pay a premium. The problem with the proxy means testing, and I've told Dr. Mwai this, is that a lot of Kenyans, and that is why I saw the CEO saying yesterday, the CEO, acting CEO SHA, saying that when they used that tool initially, it brought very crazy answers. A lot of Kenyans are going to be classified as well off when indeed they are not well off. This is the first problem with proxy means testing. The next problem with proxy means testing, we have written in the law that the national government and county governments are going to be the ones to pay for those who will be classified as indigents. Today, as we are sitting here, I do not know of any government. Today, as we are sitting here, I do not know of any government except maybe Murang'a County, which is trying to pay for its indigents, and which has actually written to SHA and invited SHA to come and proxy means test. But
the national government is also paying for the indigents.
Yeah, but that has to, they have to be reassessed. But the issue, the basic issue here is that the informal sector, and what the CS did not answer, is how are you going to get the informal sector, after you have applied proxy means testing, which I can bet is going to be a problem, to pay?
Okay, and on that note, then Dr. Moy and Dr. Nyikala, I'll come to you. So let's hear on a final attempt from the CS, and that's where, because this is a very key component. We talked about the financing, we talked about the need for the digitization of health records, albeit that the Public Procurement Disposal Act says this, but it was circumspected. But this is what she said on the means testing instrument when she appeared before Dr. Pokose and his team yesterday.
Does the means testing lead to an objective amount? That is the question.
You are not employed. What happens? You're given and you do a means testing. Once it's done, it will determine your income bracket, and based on that, then you will be told to pay a certain amount. If unable, then we have insurance premium funding, where we will be having 0% interest or very minimal interest, so that Kenyans can be able to pay for the next 12 months. So that is what we envision, that every month they will be able to deduct from what you're getting. So it will be almost similar to the people who are employed. Now, the means testing...
Where are you deducting from?
That's from where the woman works in my shamba.
Because the lady who is working in my 5 years shamba and is earning that much, how are you going to deduct it?
It will be similar to the Hustlers Fund.
How?
It will be fully be a loan. But it's a kind of...
But 0% interest.
How will you deduct it?
From a person.
Tomorrow this thing gets the
Dr. Moy, there seems to be a difficulty, is it? In as much as this is much needed. Yes, to you, Dr. Moy.
Think on two things, because one thing that I completely agree is the fact that there is a lot of information asymmetry. The information has not yet reached the people for people to know what needs to be done. And in my expectation is that as a rollout happens, much more information will be pushed to the people, more sensitization will be done so that people understand what needs, of course, to be done. But I want to highlight 3 things. One, I want to begin with the 2.75 and highlight that currently the people who are employed, and I want to begin with the employed population, the people who are currently employed, if you are earning low incomes, for instance, if you earn 6,000, your premium currently for NHIF is 5%. 5. You come down from 5 to 4 to 3. By the time you are getting to around 35,000, you are almost somewhere close to 2.75. Actually, it's 2.around 77, something like that. Now, from there, if you go to 40,000, it's 2.65. By the time you get to 100,000, it's 1.7. If you get to 1 million, it's 0.017%. That's the money that we are charging the people. Now, that is what we call a regressive system that is oppressing those who are getting less. Employed, I'm in the employed population. So the question was, why would we charge the person earning less 5%, and the one who is earning more, we charge them 0.017? It's not fair, it's not equal. But I can give you the answer. The answer is because that person who is earning between 6,000 and approximately 40,000, they are the majority, but they are the characters who have less incomes. They will never come to this table to speak how I'm speaking, and they will not go to Bujube because they will never be elected. And if you elect them, they become rich, they start talking about contributing more. So what is happening there? It is just equalizing everybody, not to be the person with one paying $1 million to pay 5%. It is to make the person who is earning 1 million to just pay 2.75, just as the one who is earning 6,000.
So 2.75% of 1 million is 27,500.
Correct.
Right?
Yes.
For the person earning 6,000, okay, let's just do the maths here. That's 165 shillings.
Correct.
Right?
Correct.
The minimum is 300 shillings.
Correct.
Is it?
Correct.
All right. So there is no, obviously, equity in the payment.
In the current system,
yeah, there's no,
it is unequal, it is regressive,
yeah.
It oppresses the poor for being poor. You pay them low salaries, and then you charge them 5%. Then others, you pay them high salaries, you charge them 0.01.
That's not the point, Dr.
That's unfair.
Right? Let's stick with the 2.75%.
Equity.
Yeah, equity. That's what we're talking about, all right?
No, it's not like
I'm drawing the comparisons here, because I'll give Dr. Nyikal the floor, but let's finish up. So for the Kenyan earning 1 million Kenya shillings, so he will pay 27,500. That's up from 1,700 under the old scheme.
Yes.
Isn't it?
Yes.
For the person earning, let's work with 100,000 Kenya shillings, okay?
2,750.
Yeah, times
2,700.
that is 2,750.
Yes.
So you have talked about the inequity here. Yes. But still, these two persons, despite the difference in terms of the deductions, do they have the same premiums again in terms of healthcare access?
Now you come to the solidarity principle.
Yeah.
The solidarity principle is that we contribute the same based on ability to pay. Because the ability to pay is measured by the proportion of your income. It's not by the value. Because that person who is paying 165 shillings out of 6,000 is a lot for them. The same way, the 27,000 person paying out of 1 million, it means something for them.
Okay.
So it is similar. It is similar. We didn't say that we go to progressive so that if you have more money, you pay more in terms of proportion. Yeah. Because that's the weight of ability to pay.
Okay. So let me ask you this.
So I didn't want to stay a lot there.
Let me put it this way, because there's an important question we need to address that the CS said. So let me put it this way. Assuming you're the person earning 1 million, so you will pay 27,500 shillings. And then I earn 100,000 Kenya shillings, I pay 2,750. Then we access the same premium. Is it fair for you? We access the same medical services?
It is equal. The equity
but
question.
Is it fair in your view?
For me, it's fair. For me, it's fair. And I want to tell you why. The person who actually will pay this 27,000, when those who he's not contributing to, you know, it's a principle of insurance, socio, you are bringing these people together. I want to highlight this. Those people who are paying 27,000, if you ask them how much they are actually contributing to the other, that money is far more than that. But what are we saying? That when you do your equal proportion of 2.75, regardless of your income, then the government will pay for those who cannot, so you don't need to support them. And those other who you are supporting, like the elderly, will be part of this scheme. You don't need to pay for them again. Therefore, you only do your part, and the other people are covered within this solidarity.
Hold it there, I'll come to you. Yes, Dr. Nyikal.
You know, basics. Social health insurance. The word is social.
Mm-hmm.
What does that, if you accept that concept, the thing, we wrote it in 2005. Social, so 2003, 2005. It brings a concept of solidarity. It actually originates from countries that have realized there should be an element of yes. Now, countries that have realized that health is a need, it's a human right, and people who are poor should be supported by people who are rich.
Yeah.
So the concept of social solidarity, why it is called social health insurance, is that the rich will pay according to the people will pay according to their income, but get services according to their needs. If you look at it, health needs are the same for everybody. If you need the cesarean section, the cost is actually the same. If you go to Nairobi Hospital, the difference may be the bed you are sleeping with and the TV you are watching. So now what we want, so the solidarity concept is what brought that. It was actually solidarity concept is what brought that. It was actually started by Bismarck. When he said, he actually the guy who said employers should pay for employees. These are the people who generate wealth for you. But then people realize in all countries, the Nordic countries, it means people who have earned more pay more. But there's even a bigger thing of solidarity in it. The young people who pay use health services more than the old people. So that again there is solidarity that those who are healthy pay for the people who are sick. Those who are young pay for people who are old. That is the concept of solidarity. You have to accept that.
It is not about fairness.
It's not. It's solidarity and equity. Because if you went that way, then people earning $1 million should be left not to pay anything, because with 27,000 a month, you can get a much better insurance, private insurance. But you are putting it by law so that there's solidarity. Now, the problem we're having in the country, we have a country that has accepted capitalism to an extent that the suffering of the poor is not an issue. And that is the problem we have in the US, where Obama was fighting for Obamacare, which is based on this social solidarity. And the Republicans are saying he wants to kill private health care. So they are for private health care. So that solidarity is what brings these differences. So, having said that, then you go to means testing, and there's a problem. We are, even more here, I think, take a bit of this. Means testing cannot be used for two things you are trying to do. One, you are assessing people who are self-employed as to how much income they are earning to determine how much they should pay. That you have a lot of difficulty using means testing. Now, what means testing is for is identifying the indigent, people who are totally unable to pay, so that the government can pay for them. He's saying he has written a lot on it. I'm saying I tried it when we were bringing social, I actually tried it when we were bringing cash transfers for elderly persons. We didn't have enough money, so we had to get a way of picking the people who are most needy. So when we come to that, with indigent, it is much easier, although there are problems inherent in means testing, but it is much easier to do that, because once you have decided they are unable, the government pays for them. And that is why this thing was not implemented in 2005, when the Ngilu bill passed, when President Kibaki just asked, what is the level of poverty in the country? And that time the figures were showing the indigent were about 51%. And he asked, how much money will it cost? And we said, and then he said, who is to pay? The government. He said, we are not able now financially to do it. That is why it was shelved. But let me tell you what it did. It is that document that we presented at WHO in the year 2005 as a means of getting health for everybody. The whole world went for it. And that is what brought the concept of UHC. We wanted to say that social health insurance be used by all countries to give cover for everybody. So it's the Americans and the British said, no. You cannot impose one system all over the world. Those who can use their money to pay for their people, like the British. So then now let me come to the problem. Now, let me come to the problem.
Because we are out of time.
No, the problem of self-employment.
Yes.
If you assess and you give somebody the information and he keys in, and the information tells him or her that this is your level of income, therefore you should pay this much. The question is, how do you get that money paid into the system?
Yes.
Thank you very much.
We're out of time,
yes,
gentlemen. I'll give you 30 seconds.
30 seconds is valid.
Yes, 30 seconds. Because that was still unanswered by the ministry, by the LCS.
Yes.
Because there are two things.
Dr. Njikal, some order. Yes, Dr. Mwai.
You need to call
He's now orderly.
I'm just giving you information.
Yes, briefly.
So I first agree with him that 2003, they did a good work. They did not implement it. We are trying to implement.
Yeah.
All right? I'm happy he's here, because these are facts.
How will you implement? He asked a very good question
that are important.
in that session.
I just wanted to highlight the mean testing, because it's where we are. That every Kenyan, whether employed formally or informal, is payroll or non-payroll, they have income, because we have said the indigents will be identified and those government will pay for them. We are now dealing with a population of Kenyans who have income. Now, those are the ones that are supposed to be subjected to proximing testing. There are many types of proximing testing. And I mean, I'm a student of economics. Health economics is what I eat on. So the models that we have developed is a trained model. And the trained model says like this. You give me variables that are highly correlated to income, and they give you an indication of what your income is. All right? Now, that is where you will apply 2.75 to that income that is projected. Now, the model we have is in two phases. It is projecting, because we have been training this model. Again, it is the issue of 2000, that was the test. We went back to check what it is doing.
Thank you.
But we had used 16,000 households to actually develop this.
Thank you, Dr. Thank you. Thank you, Dr. We are absolutely out of time. Your time is all appreciated.
We need more time.
No time.
Next time.
We even sample the feedback. But we were here last week, so we'll be there again.
Okay.
By the grace of God. So much appreciated, Dr. Brian Lishenga. All your presence is here valued. Thank you. He's the chairperson of the Kenya Rural Urban Hospitals Association. Dr. James Nyekal is a member of the Health Committee of the National Assembly and represents Seme constituency. His chairperson is here, Endebess MP, and as well Dr. David Moai, who is President William Ruto's advisor on health financing. Your time is all appreciated. So you spoke like doctors. Did you sign the impeachment, yes or no?
I've signed the impeachment.
Dr. Nyekal, did you?
Yes.
Thank you. So we'll see you tomorrow morning here. Up next is Social Hour. Good morning.